Hi, my name is Jorge Plutsky. I'm the Director of Preventive Cardiology at the Brigham and Women's Hospital, and it is a pleasure to be speaking with you today about lipid disorders, providing an update about that in the context of a review of current issues and evolving therapies. My conflicts are listed here. It's important to start off with a global overview of cholesterol transport, and I just want to highlight a few of these key topics because they're very relevant as we start digging more into the newest data and new therapeutic options. The liver, of course, is central to cholesterol transport and lipid metabolism. We export triglycerides and cholesterol in very low density lipoproteins, VLDL, and in a process involving metabolism, the triglycerides in the VLDL, which is triglyceride rich, are cleaved off. And over time, one ends up with an increasingly cholesterol-rich particle, which is LDL, which is taken up by LDL receptors, either in the liver or in the periphery, where the cholesterol that's offloaded is used for many different things, including cell membranes, the making of hormones, and the like. The other source of cholesterol comes from the cholesterol we eat, and also from bile, which is mainly cholesterol, and those substances are taken up as chylomicrons. Chylomicrons also being triglyceride rich, but having cholesterol in them. And again, metabolism extracts the triglycerides, and one is left with chylomicron remnants, which are also taken up by the liver. And then the last component is HDL, which we think of as participating in reverse cholesterol transport, HDL moving cholesterol from the periphery back to the liver. Now, we mentioned triglycerides, and just to touch base on what triglycerides are, these are three fatty acids linked to a glycerol backbone, hence the name triglycerides, and it's through the action of lipase cleaving off fatty acids that one gets at the fatty acids, which are used for energy or are stored in fat, and contribute to a resource of energy as needed. And again, those triglyceride-rich lipoproteins are VLDL coming from the liver and chylomicrons coming from the gut. Now, 20% of triglycerides are carried in VLDL particles, and that ends up accounting for the Friedewald equation, which basically takes everything from total cholesterol, subtracts HDL, subtracts VLDL, and by supposition, what remains would be a measure for LDL. Now, since 20% of VLDL is carried by triglycerides, the Friedewald equation then becomes the triglyceride value divided by 5 gives you a measure of VLDL, and that's the Friedewald equation. It's conceivable in board settings that someone might ask you to calculate an LDL. And in your own laboratories at work, they are typically calculating an LDL. It's thought to be valid except when the triglycerides start getting significantly elevated, in which case a direct LDL can be measured as well. But this equation actually holds pretty well in the absence of significantly elevated triglycerides. Now, that LDL receptor, of course, is very important. It's taught us a lot about cholesterol metabolism, and here's the structure of it. This is not particularly critical other than to say that the part of the LDL receptor that sticks up out of the cell membrane can involve many different mutations in it, resulting in familial hypercholesterolemia. And because those variants can happen in many different places, one gets different levels of LDL receptor activity, even in the setting of familial hypercholesterolemia. So this LDL receptor appears on the surface of cells, will bind and take up LDL particles and bring them into the cell, and then the LDL receptor can return to the surface for another round of activity, and that's going to come up later when we talk about new therapeutics. And we know that there are defects in these many different aspects of handling of the LDL receptor. LDL receptor activity then varies as a function of these different biological roles and where the defect might be in that processing. And as a result, for therapies that involve increasing the LDL receptor, like statins, you can get a variable response depending on where the defect is in that process. It's worth knowing a little bit about familial hypercholesterolemia because it could come up in a board setting, but homozygous familial hypercholesterolemia is rare. There's debates about its frequency, but 1 in 1 million would be a common perspective on it. Differences in the receptor activity and is present can be often in childhood, seen with xanthomas. I'll give examples of that. And the LDL levels are very high. The total cholesterol levels are very high. Atherosclerosis is quite prominent. And the treatment, of course, is statins, adding ezetimibe, PCSK9 inhibitors, even bile acid sequestrants, and ultimately going on to ileal bypass, liver transplant, apheresis, and interest in gene therapy. Much more commonly encountered is heterozygous FH, where one of the alleles is mutant, is also associated with early onset coronary disease, tendinous xanthomas. One should rule out thyroid issues or liver issues, could show up in a board setting, and again, variable clinical presentations depending on the defect. In terms of FH, there are 4 different genes that can show up in a phenotype that looks like familial hypercholesterolemia, and those are listed here. The most common being LDL receptor, but defects in ApoB100 particle, this ARH adapter, and PCSK9 are very rare, and I'll return to these, but these show up in very similar kinds of patterns with elevated LDL levels and increased onset of cholesterol complications. The diagnosis for familial hypercholesterolemia is clinical and is felt to be present when the LDL is greater than 190 and there's a tendinous xanthoma or even higher LDL levels with a tendinous xanthoma, and a strong family history and first-degree relatives can also support this diagnosis. Here's an example of those tendinous xanthomas. So these are on the tendinous surfaces. They are occurring. One place that can happen is the Achilles tendon, as shown here. A thickened Achilles tendon would be an example of that. There are criteria out there for diagnosing FH. I won't spend too much time on that. One is the Dutch lipid criteria. One is the Simon-Broom criteria. I don't think this is something that most people know, and it's available online, but align with what I just told you about running through LDL levels, family history, to make it a diagnosable finding. Now, in terms of the current guidelines that may be in the process of changing, which we'll talk about in more detail, 4 patient groups were identified of individuals who should be on statin therapy, and related to what we were just talking about, one of those 4 groups are people whose LDL levels are 190 or greater. And that's because of what we just talked about, that when your LDL level is in this range, there's a greater chance that you have some genetic basis for hypercholesterolemia. Now, as we move out of that genetic issue to more common scenarios, we've known for a long time of there being a relationship between cholesterol levels and mortality, and that's present globally. This is Ansel Keys data in the 7 country studies, but the question was, if you took any patient with a given LDL, given total cholesterol, and moved them down, could you change outcomes? And that is what the statin era has basically solved for us, and it's worthwhile knowing that data. The first study was the 4S study that showed that simvastatin in people with a prior heart attack and LDL of 190 led to a mortality benefit with about a 30% decrease in risk, and really began remaking our approach to these issues. And on the other end of the spectrum, here's AVCAPS, which is a primary prevention study. And here you see the characteristics. People on average had an LDL 150. In this particular study, their HDLs couldn't be too high to get in, and in this case, lovastatin led to a significant decrease in events. And really brackets the ends of these statin trials of very high risk in 4S, and now primary prevention AVCAPS with an average LDL, all of them showing benefit. Importantly, in terms of the evolution of guidelines, it's worthwhile noting that if one used the guidelines in place at that time, that most people in AVCAPS would not have been treated. And so obviously these things evolve, and it's reflected in the number needed to treat. In and that's evident in the events that occurred in the placebo group in these various trials. You can see here the number of heart attacks in the placebo group in 4S was about 23. It's much lower in AFCAPS, about 3, and that relates to the number needed to treat to prevent an event. In 4S, it's very clear-cut, the benefit. And now in terms of, with more and more evidence, we accept this number needed to treat in appropriate patients out of AFCAPS, which was 50. The cholesterol guidelines had a lot of controversies related to them in terms of their approach. They really took a different kind of strategy, really best thought of as being a scientific statement as opposed to true guidelines. We are expecting new guidelines, so I would not anticipate a lot of board-type questions on guidelines, given the fact that they're in evolution and thought to be perhaps as early as November of this year being updated. But they did take this new strategy of saying if patients fell into one of these 4 groups, they should be on statin therapy. Some of these age cutoffs are a little bit artificial, and they're present because that's what was studied in the trials, and that's why I say it's really a scientific statement. But in the presence of known atherosclerotic cardiovascular disease, patients should be on a statin. If the LDL is greater than or equal to 190, they should be. If they have diabetes, they should be in this range of 70 to 189. And you can see here perhaps some artificiality to that. Certainly if the LDL is greater than 190, we would be treating as well. You'd then come back to this criteria for treatment. That's why it's present in terms of age, 40 to 75. And then if you don't have any of those reasons for treatment, but your risk calculates to being greater than or equal to 7.5% over 10 years using a risk calculator, then you would also warrant statin therapy, with the intensity of therapy being based upon these parameters in terms of what was studied, with these groups getting either high intensity statin, which is atorvastatin 40 or 80, or rosuvastatin 20 or 40, a moderate intensity statin being the lower levels of those, and I'll revert to that. These guidelines were controversial in not using target LDLs. We'll see whether the new guidelines embrace this, given new evidence we have that I'll talk about. But in those first 2 patient groups, you'd be using a high-intensity statin. The second 2 groups, a moderate-intensity statin, following those guidelines. Now, there was plenty of evidence that did argue for lower LDLs being better. Here's one example to that. In people with a known history of cardiovascular disease, here's simply the placebo versus treated groups lined up across the spectrum of these trials, and you see this straight line. It's flatter in primary prevention trials, but there's still a relationship to it, and did raise questions about whether lower was better. And one of those studies that I think is relevant to this idea about LDL and targets was Prove It, which looked at patients who had just had an acute coronary event and studied pravastatin 40 versus pravastatin 80, achieving LDLs of 95 versus 62. And this was a positive trial where the lower LDL was better, statistically significant. You could say, okay, so why aren't we using targets given this kind of data? And it would be because from a pure scientific perspective, it's not using the same statin titrated to a certain LDL goal and looking at outcomes. It's 2 different statins. But I think most people looked at this and did see this as evidence that lower was better, given that pravastatin also had positive trials showing benefit prior to this study. Now, one of the things this overview of cholesterol transport highlights is another therapeutic opportunity that for a long time it had been recognized that we flux a lot of cholesterol through our gut, through bile acids, and is it possible to avoid the reabsorption of that cholesterol and thus lower circulating cholesterol levels? That's how high fiber diets work. That's how cholestyramine bile acid sequestrants work. But a new target came along in the form of MPC1L1, which is the target of ezetimibe, which is not a statin. And what the evidence showed that when added to any statin, ezetimibe adds about another 15 to 20% LDL lowering, independent of statins. And this was studied in the Improve It trial, looking to see whether or not you could improve outcomes when adding it to ezetimibe. This study was controversial as it unrolled, but here you see the impact of adding ezetimibe to simvastatin, where you did achieve a lower LDL, 54 versus approximately 70, consistent with that 15 to 20% that I pointed out. And this was a positive trial with a number needed to treat, not very different than other studies we've seen. And so there is evidence for ezetimibe as decreasing events. It is probably underutilized in the population. The data for ezetimibe lines up very well with the genetic data for people who have variants in MPC1L1. And we'll see whether the new guidelines based upon the ezetimibe data and the PCSK9 data I'll talk about are going to embrace target LDLs again, as many people think it should. Now, important observations arose through people who go through their entire life with low LDL levels, and that was found as shown by the group at the UT Southwestern, and that data showed that people with low LDL levels as a result of loss of function of PCSK9 had significantly lower LDL levels as compared to people who had missense and no nonsense mutations in PCSK9 that looked very much like the general population. And what were the implications of going through your life with lower LDL levels? And what the finding was that these people were completely normal. They had no issues in terms of muscle function, cognitive function, bearing children and the like. But the one thing that was different was they had significantly less in the way of coronary heart disease. And of course that set off the interest in replicating this for patients by targeting PCSK9 for therapy. And I think this is very much supported by the genetic evidence, because in people who have a gain of function of PCSK9, more PCSK9, as shown here, actually look exactly like people who have familial hypercholesterolemia, very supportive of the role of this target in cholesterol levels and clinical outcomes. And that's just highlighted here with a gain of function, much higher LDL levels with a loss of PCSK9, lower levels, and supported the idea of targeting it. And we came to learn that this PCSK9 protein is secreted by hepatocytes and attaches to the LDL receptor and targets it for degradation in lysosomes rather than allowing it to return to the surface for another round of clearing LDL. So with the PCSK9 gain of function, more PCSK9 around, you're going to degrade the LDL receptor more, your LDL levels will rise, versus a loss of function where the LDL receptors are consistently being put back up on the surface of the cell to clear LDL. So we now have data looking at the effects of the drugs that target PCSK9. That's done by using an injectable antibody. Fourier was the first study using evolocumab. And of course, standard therapy is now with statin therapy. So these were individuals whose LDLs, despite therapy, remained greater than or equal to 70. And following in this cohort of some 27,500 patients with known established cardiovascular disease, what happened to them. The characteristics are here, very typical kind of populations. We might expect the average age of about 62. Most of them had coronary atherosclerosis and a prior MI, and plenty of the usual cardiovascular risk factors. And here's the dramatic efficacy of these agents in lowering LDL, taking individuals from an LDL of about 90 down to around 30 at the end of the trial, a little bit higher. And this was a positive study with a decrease in the primary endpoint of cardiovascular events, and was statistically significant, as well as with the secondary endpoints around a more focused cardiovascular event. So a positive trial, very important, demonstrating the benefit, very well tolerated, with the only issues really being some patients having a little bit of an injection site reaction, not even very different from placebo, but highly precise since you're injecting an antibody. Now, we've also had presented but not yet published the Odyssey outcome trial, which was with the second kind of agent. Evolocumab is commercial name of Repatha, alirocumab is purulent. And in this 18,000, almost 19,000 patient study, these patients had established coronary disease, but were presenting at the time of an acute coronary event. And similar kinds of efficacy on LDL lowering, various trial issues influencing the trends over the LDL, including the fact that this trial did include backing off therapy if the LDLs got too low, since there was concerns at the time about that. But it was another positive outcome trial with PCSK9 showing a significant reduction in events in this patient group. There was evidence for mortality benefit as shown here. There's also some subgroup evidence suggesting that the benefit was really amongst those patients whose LDLs were greater than 100. This is a little bit different than in the Fourier trial, which showed benefit really across LDL levels. Still under discussion about that. We have had one update to guidelines that did begin embracing non-statin therapy like ezetimibe, and situations where you might consider that, and also beginning to think about PCSK9 and when you would do that. And the case was made here that LDLs under 70 are reasonable and patients are considered high risk, and the use of these agents was endorsed, whereas the prior guidelines had not. And there's a list of scenarios in which that might be considered, some of which are laid out here. Not all of these are recognized by payers, but can be relevant for clinicians thinking about who's at high enough risk where I might say I need to move on to adding these other therapies. And I think we'll continue to see this and should be updated in the next iteration of the guidelines. Now, an important clinical issue that arises very often is the statin intolerance. And one can return to the statin trials to consider this. In 4S, it's interesting to note that more people stopped their statin than stopped placebo. Not statistically significant, but it's reflective of what we subsequently saw on this issue of statin intolerance. There's been interest in the idea that PCSK9 may be particularly useful for patients who have statin intolerance, since it's not a statin. And in this study, the GAUS-3, studying patients with statin intolerance, this group was enrolled and first went through an initial run-in phase where they either got a statin or placebo and then crossed over, and could only move on to the actual PCSK9 trial if they had muscle symptoms on the statin but not on placebo. And it's interesting to see that in this study there were a significant percentage of patients who had symptoms on placebo but not the statin, or had them on both, on the order of about 30%, a significant percentage who didn't have it on either. I think this really is the issue with statin intolerance. And we participated in collaboration studies looking at this, and here's a real-world scenario of looking through chart records of what happens to people who get rechallenged with a statin if there's a mention of possible statin intolerance in their chart. And the finding here was that the majority of patients rechallenged with a statin continued on a statin over time. Statin intolerance had been thought of in terms of increased liver function or increased CKs. Prior guidelines had said that one could tolerate liver function tests up to 3 times the upper limit of normal, CKs up to 10 times the upper limit of normal. It could be relevant in a board setting, asymptomatic patients not stopping a statin if their CK is elevated. They have no symptoms, but it's only 2 or 3 times the upper limit of normal. More often patients complain of myalgias if they have statin intolerance, which may or may not have CK changes. There's a higher incidence of this than what's been seen in clinical trials, where the rate of intolerance was often like that of placebo. As mentioned, in the real world, that seems to be higher for unclear reasons, but often patients can work through their statin intolerance by trying a different statin. Importantly, rhabdomyolysis is quite rare and involves exposures on the order of 1 in a million. And so it's not much of an issue, sometimes of concern with concomitant therapies, more often seen with some statins that are no longer on the market. But can be seen with concomitant use with certain antibiotics. Some of the older HIV medications can be more of an issue. So clinically, we suggest that patients with statin intolerance, that one recognize that it may not be the statin. Real-world scenarios are that it may be more often at higher doses, that re-challenging patients with a different statin sometimes can work at a low dose and then working up from there. Let's talk a little bit about triglycerides, and let's start off with a question about how does one transport triglycerides? A, through chylomicrons that take up triglycerides from the liver. B, through very low density lipoprotein secreted from the liver. C, through HDL, which does reverse cholesterol transport. The metabolism, that LDL comes from the metabolism of VLDL, including removing its triglyceride content, or the clearing of LDL from the circulation that involves the LDL receptor and the action of PCSK9. So in terms of triglycerides, the correct answer here would include B. Chylomicrons are not taken up from the liver, they're coming from the gut. VLDL is secreted from the liver. HDL does not transport triglycerides, so that would not be correct. LDL does derive from the metabolism of VLDL, so B and D are both correct. And E is correct, but it's not specifically related to triglyceride. It has to do with LDL. So I would say the answer here would be B and D. Now, for a long time, there's been the recognition that even in individuals with the same LDL, higher triglycerides are associated with higher risk, and that's been seen in many different ways, many different studies. This is just one example and has raised this question of, are triglycerides something that should be treated? Here's another example of that, suggesting that in patients with the same LDL, that it's the higher triglycerides that are conferring greater risk. And it's important to know for boards and clinically that most hypertriglyceridemia comes from other issues, and running through this list of why someone's triglycerides might be high is important. It can involve diet, like high carbohydrate intake is often seen with obesity. Diabetes, especially if it's not been diagnosed, also with prediabetes. People with high triglycerides should get a TSH to rule out thyroid issues. Nephrotic syndrome can contribute to hypertriglyceridemia, so urinalysis for proteinuриas can be important, as identifying that it's also seen in pregnancy and polycystic ovarian syndrome. Medications are a common cause of high triglycerides, especially thiazide diuretics. It can also happen with estrogens. Other hormonal modulators, tobacco raises triglyceride levels, and so when one sees a patient with high triglycerides, running through this list is important. The minority are due to a genetic issue with triglycerides. And this may well be proatherogenic. Lifestyle can have a very significant impact on triglyceride levels. Modest weight loss can achieve that, and moving patients away from a high carbohydrate diet can be very effective, as can increased activity. And this is a first-step approach to patients with high triglycerides, is seeing if you can modulate them through lifestyle interventions, looking at secondary causes. Now, high triglycerides contribute to fatty liver and are commonly seen in diabetes and with increased VLDL synthesis and secretion. And so these high triglycerides are related to high VLDL levels, promotes fatty liver. There are changes in metabolism that lead to smaller LDL size, small dense LDL that may be more atherogenic. And as a result of small LDL size, you get higher ApoB levels and higher particle numbers. And one also sees changes in HDL, all of which might contribute to the atherogenic state that's thought to exist with this, with lower HDLs, and changes in HDL that may further complicate this picture. So what about treating high triglycerides? The main treatment for that is fibrates. We have one trial the VA hit in 2,500 men with this kind of lipid profile, LDL 111, triglycerides of 161, HDL 32. The fibrates lowered the triglycerides and raised the HDL. Now, very often this kind of profile is seen in diabetes and insulin resistance, and that was the case in VA-HIT. And importantly, this was a positive trial with significantly decreased events. So here's a fibrate trial also having significant efficacy on reducing events. And this is without any statin use. And analysis of VA-HIT suggested that the benefit was really driven by the patients with diabetes. And so this prompted the idea that perhaps fibrates should be first-line therapy in patients with diabetes. In the field study, which examined another fibrate, fenofibrate, in a cohort of 9,800 patients, all of whom had type 2 diabetes. And that was a negative study, did not show a benefit. Now, in field, there was subgroups and secondary endpoints that were positive, a decrease in non-fatal MI that was significant, a decrease in cardiovascular events and coronary revascularization, all encouraging, but actually an increase in cardiovascular death and an insignificant change in CHD events. And so led to a quandary. Now, if one analyzes field, unlike VA-HIT, where there was no statin use, in fact, in field, a disproportionately higher number of patients in the placebo group received a statin, and maybe this modulated the benefit that might have been seen in field. The Accord study examined the addition of a fibrate to a statin, simvastatin, in some 5,500 patients, and here their numbers are at baseline, LDL of approximately 160, LDLs of 100. And fibrates in this trial, as we know they do, raised HDL and lowered triglycerides, both of which were significant. And this was also a negative study, no change in cardiovascular events. Now, the subgroup analysis here is often pointed to, and I think can be relevant for management, in that where one sees benefit on patients who had significantly elevated triglycerides and lower HDL, as shown here. And this is actually similar to what's seen in the subgroup of high triglycerides and low HDL in other fibrate trials, and is suggestive of the fact that maybe these agents need to be used when the trigs are significantly high and the HDL is significantly lower, which has not been part of most entry criteria before. There continues to be interest in fibrates, and additional trials will be coming out. I think for most patients, one would restrict fibrate use to either patients with significantly elevated triglycerides in a pancreatitis range greater than 500, especially if they have a history of pancreatitis. But in more common patients, you might think about doing this in higher risk patients who've had a prior event whose trigs are significantly elevated and HDL is lower, while we await further trial data about whether that's an appropriate strategy. Maybe there are other ways, other fibrates, to address this. One other way to treat elevated triglycerides is with omega-3 fatty acids. This often has to be 2,000 milligrams or greater. There's various formulations of different omega-3 fatty acids that are out there, some of which have ongoing trials. It is another alternative in terms of lowering triglycerides. There has been some evidence to suggest fatty acids can decrease cardiovascular events like in Gellus, but in other studies it's been less evident, and lots of questions about the kind of fatty acid and the source of it that may be relevant. Now, as talked about before, we know different lipoprotein particles carry triglycerides and LDL to a different extent. The apolipoproteins on lipoprotein particles act like a zip code to tell these particles where to go. ApoB being present on the triglyceride series involving chylomicrons and VLDL and ultimately LDL. We don't associate risk with HDL. We do with LDL, and the case can be made that actually risk is associated with all of these ApoB containing lipoproteins. Out of the gut, the apolipoprotein B is B48, whereas from the liver it's B100. And one could say that a measurement of these would be more reflective of risk, and the evidence supports that. All these particles are contained with this idea of non-HDL, and that's simply a calculation of taking total cholesterol and subtracting away HDL, and you're left with this measure of non-HDL, And the notion for this has been in guidelines that your non-HDL target would be 30 points above the target LDL, and this might lead you to intensify statin therapy, add another agent for LDL lowering, add a fibrate, think about fish oil, are all ways that you might try and address this additional risk that might be present with non-HDL. We'll see whether or not the next iteration of guidelines continues to embrace non-HDL, which really becomes a way of estimating particle number in ApoB to some extent. Lipoprotein A is an interesting molecule because it is an untargeted, unmet need in terms of risk. It contains LDL, as shown here, but through a bridge connects to this apolipoprotein A structure, and this entire macro complex is what lipoprotein A is. And there's plenty of evidence to say that Lp(a) is associated with risk, even to an increasing extent. Here's a paper from 2009 showing that the number of variant alleles you had in terms of Lp(a) was associated with a degree of risk. We've not yet had a good therapy for intervening on Lp(a). Niacin does lower Lp(a), but has not been shown to have benefits in trials, and so that, combined with its poor tolerability, has really decreased the use of niacin. Statins have no effect on Lp(a). It's not cleared by the LDL receptor. But one strategy for people with elevated Lp(a) is to run their LDLs even lower, because LDL is part of this. PCSK9 inhibitors decrease Lp(a) in the order of 30%, not likely to be the reason why you get approval for a PCSK9 inhibitor. There has been a question about thrombogenicity that may be part of the Lp(a) story, and so some have advocated for more aggressive antiplatelet therapy. There's not enough data about Lp(a), and there should be more added to it as more groups think about targeting Lp(a) and new therapies for targeting it, and I think those therapies will come forward. We certainly try and minimize other risk factors for such patients. And I think in a board context, I want to run through a few genetic scenarios that can come up on a board setting. In terms of primary causes of hypertriglyceridemia, one of them is so-called type 3 hyperlipoproteinemia, which involves an increased amount of VLDL. The characteristic pathognomonic finding are palmar xanthomas, this yellow crease that's here. You can also have tuberous xanthomas. The most common genotype is an E2. They can be very responsive to fibrates, and they show up with very high triglycerides. And so in patients with very high triglycerides, you would really begin with fibrate therapy. Statins can have an effect on triglycerides. It may be an adjunctive measure, but you'd be looking for the fibrates because of the concern about pancreatitis. And then separately, perhaps addressing addition of statin in general tends to be quite well tolerated. Here's a skin deposition of triglycerides. This kind of eruptive xanthoma is seen with hypertriglyceridemia. And so here's another question. Targets in cholesterol and lipid management that have shown decreased cardiovascular events include statins, the reduction of LDL level, fibrates, and reducing triglycerides, increasing HDL, PCSK9 inhibitors that reduce LDL, and niacin, which increases HDL and decreases lipoprotein A levels. So one could go with all of these, A, B, and C, or just A and C, and the correct answer here would be A, B, and C. Niacin has not shown benefit in reducing cardiovascular events, whereas the others all have. With the fibrates, it would be VA hit, even if it wasn't seen in field or in a cord combined with a statin. Another genetic abnormality that can show up in board settings is Changiers disease, which is very low HDL levels, autosomal recessive. You can get accumulation of lipid products in the tonsils, so shows up as orange tonsils due to a mutation in ABC1, which is a transporter for HDL. The association of Changiers with cardiovascular risk is a little bit less clear-cut, but if one sees tonsils, and particularly if they have a more orange appearance, certainly a zebra. shows up. What does one do about triglycerides? Well, here's a clinical perspective on this. Here's a patient with a reasonably controlled LDL level, low HDL, and elevated triglycerides. And certainly one in this patient would think about stopping their hydrochlorothiazide. There's other alternatives for treating their blood pressure. This is a situation where lifestyle matters, and even modest adjustments can make a big impact. One could consider a fibrate therapy, most typically fenofibrate, which is better tolerated with a statin, as opposed to gemfibrozol. The risk is significant. Established cardiovascular disease, high triglycerides, low HDL. And certainly, if there's a history of pancreatitis, high triglyceride levels, you'd be thinking about adding a fibrate. And as mentioned, alternatives are lifestyle interventions and fish oil, as long as the EPA DHA levels are high enough, above 2,000 milligrams a day. HDL has a very steep curve associated with cardiovascular risk, but thus far, efforts to raise HDL through therapies have not decreased events. And here's one example, AIM High, that showed no difference in people receiving niacin. Even though there were plenty of events, there was no difference. And as mentioned, often not well tolerated. So I think we use relatively little niacin. Some patients with elevated lipoprotein A levels who like the fact that their Lp(a) levels came down with niacin, but not often used. So to summarize a little bit of what we went over in this talk in terms of current lipid management, in terms of the guidelines, there is evidence that lower is better. We have been using LDL targets all along, but I think the new guidelines may well embrace that. The patient subgroups are useful, I think, and they are supported by evidence. Ezetimibe is underutilized and can help, often lowering LDL 20%. Statin intolerance is often not real statin intolerance, so be cautioned before you would label patients being statin intolerant. Triglycerides do matter. We certainly need more evidence, but you have to run the list of secondary causes, recognize how important lifestyle is in this setting in terms of changing numbers. Can consider fibrates if the triglycerides are significantly elevated, and especially in that setting, prior history of pancreatitis. And you can think about them in patients with significant cardiovascular risk and high trigs and low HDL, although the evidence is not as strong as we would like. It's subgroup data. PCSK9 inhibitors are a major advance when patients remain with elevated LDL levels or cannot take a statin. And approval can be gained for these and should be used and are probably underutilized and can be quite effective. And those genetic causes of lipid abnormalities I mentioned in terms of FH, high triglycerides, change years. And in a board setting, you might see rare cases about rhabdomyolysis, and it might be worthwhile just reviewing the meds where that's a concern. HIV meds, antibiotics, certain antibiotics, being more common scenarios where that can come up. And so let's conclude with one more question. Which of these patients, based on the 2013 guidelines, would warrant therapy? A 72-year-old with a prior history of carotid endarterectomy, a 45-year-old woman with an LDL of 195, a 50-year-old man with an A1C level of 6.2, a 40-year-old man with an LDL of 110, but a history of cigarette smoking. And so who would fall into those guidelines? The 72-year-old has a known history of cardiovascular disease, so you would treat him. The 44-year-old woman has an LDL greater than 190, so she would be treated. This 50-year-old man has pre-diabetes but doesn't have established diabetes. If diabetes were established, then you would treat, but in this case, you wouldn't be compelled to. This 40-year-old man with an LDL 110 has a significant risk, and you might opt to treat, but in terms of those patient groups, the risk calculator would not likely reach the 7.5% threshold because of age, which is a major driver of risk, including with the risk calculators and with that lower LDL level. And this refers to that threshold of a 10-year risk greater than 7.5% as being a threshold. In the real world, you might look at this patient and say that given the the cigarette smoking, that you want to initiate statin therapy even at a low dose, and certainly statins tend to be very well tolerated and are even used over the counter in some countries, and so that could be debated. But in terms of the guidelines, if that risk calculation didn't achieve greater than 7.5%, you wouldn't use it. So the more clear cut are cases 1 and 2.